Hello, I'm Dr. Craig Childress. I'm a clinical psychologist in Pasadena, California, and I specialize in working with children and families around issues of attention deficit hyperactivity disorder, parent-child relationship problems, angry, oppositional, defiant children, marital problems, things like that. Now, in this video series, I've been discussing a particular type of parent-child relationship issue that I refer to as a parental alienation dynamic. And in this set of video segments, I'm going to begin to discuss the treatment-related issues that we face when we begin to work with children and families who are expressing an alienation process. Let me begin the discussion of treatment-related issues with a more general discussion of developing treatment plans within the context of a family setting. As a clinical psychologist who works with children and families, there are multiple participants in the treatment process. There's both the parents and the child. And each of these participants may have a differing agenda and a differing desire for treatment outcomes. And these differing agendas may not always be compatible with each other. And so as a clinical psychologist who is developing a treatment approach and treatment plan for the child and family, it's important to maintain a focus as to who's the client. Whose best interests are we working for as a clinical psychologist? And from my perspective, I adopt the child as my primary client. And so from my perspective as a child and family therapist, it is the child's emotional, social, and psychological well-being that is driving the development of the treatment plan and the goal for psychotherapeutic outcome. Now, to the extent that the developmental and emotional and social and psychological needs of the child are also the primary concerns of the parent, then we can all join around the treatment goals and the treatment plan to achieve that. However, to the extent that parents may have other agendas that do not place primacy on the child's emotional, psychological, and developmental needs, then there will be conflict between our differing agendas regarding the outcome of therapy and the treatment plan. And those differing agendas need to be discussed and clarified at the outset of treatment. And this is particularly relevant to the treatment of the alienation process because the treatment-related outcomes desired by the alienating parent, by the beta parent, are very, very different than the treatment-related outcomes desired by the targeted parent, the delta parent. Now, to the extent that the child is in a fused psychological relationship with the beta parent, with the alienating parent, the child will be expressing treatment-related desires that are identical to that of the beta parent, the alienating parent, which is a complete cutting off of all relationship with the targeted parent, with the delta parent. However, as a clinical psychologist, I need to take a look at what the emotional, social, psychological, and developmental needs of the child are, and to develop a treatment plan that is in support of the child's psychological and emotional development. And in that regard, once I make the diagnosis that there's a process of the shared psychotic disorder, that the child is in a fused psychological state with the beta parent, then I need to make an independent assessment of what's in the best interests of the child. And those assessments may differ from the treatment-related desires of the parents. In addition, while the targeted parent may have as their agenda a desire to restore the relationship with the child, that's not necessarily my primary treatment focus. My primary treatment focus is on the well-being of the child. Now, to the extent that that well-being is supported by a relationship with the delta parent, with the targeted parent, then that becomes a treatment goal. But the restoration of the relationship between the targeted parent, the delta parent, and the child is secondary, from my perspective, to addressing the emotional, social, psychological, and developmental needs of the child. Now, from that overall general context, there are three primary focal areas that are important to address within the alienation process that are supportive of the child's healthy development. The first has to do with the triangulation of the child into the marital conflict. This is at the core of the clinical issues that are problematic within the family. That spousal conflict or marital conflict needs to be maintained within the marital unit. And it becomes highly problematic when the child is triangulated into the marital conflict and is being used as a weapon by one parent against the other parent. And that's the process that's occurring within the alienation dynamic here. And so the first treatment focus needs to be extracting the child from being triangulated into the marital conflict and returning the child to their legitimate role as a child who is able to maintain positive emotional relationships with both parents. And so to remove the child from the marital conflict. The second focal area of treatment needs to be to address the child's enmeshed psychological relationship with a parent who has significant Axis 1 and Axis 2 psychopathology. And this is subsumed under the diagnosis of the shared psychotic disorder, the shared delusional disorder. We need to address the child's fused psychological state with the alienating parent, by which the child is adopting the meaning constructions of the alienating parent, the self-structure organization, and the psychopathology of the alienating parent as expressed towards the targeted parent. As I described within the context of the transgenerational transmission of trauma, that the overall delusion is that the current relationship patterns are simply a reflection of early childhood relationship patterns that are embedded within the neurological networks of the beta parent, the alienating parent, and the child is merely playing a role within this reenactment of the beta parent's own early childhood traumatic relationship processes. And so the child is being robbed of their own authentic childhood and instead is simply acting out a role in this reenactment narrative of the trauma. And so it becomes important for the healthy emotional, social, and psychological development of the child that we restore the child's authentic childhood and allow them to have authentic relationships with everybody involved, including the targeted parent. And so addressing that shared delusional disorder is the second focal area of treatment. The third focal area of treatment is to express the child's expressions of the personality disorder dynamics of the alienating parent, of the beta parent. That the child, because of this fused psychological state with the alienating parent, is expressing the Axis 2 psychopathology of that parent, the self-inflation, the narcissistic sense of entitlement, the narcissistic rage, the borderline processes of a fear of abandonment and splitting, whereby the beta parent is the never abandoned parent, while the delta parent is the entirely abandoned parent. And so all of these underlying psychopathology of the beta parent is being expressed symptomatically by the child. And we need to address that process and return the child to sort of an authentic self-expression rather than this incorporated, transferred expression of the psychopathology of the beta parent. And so I'll be addressing how to go about addressing these three primal focal areas in the next video segments.